Welcome, welcome, welcome in everyone. Welcome to Care Concierge with CAREPATROL, where education is the heart of everything we do. We're a little bit like a healthcare realtor at CAREPATROL. We're paid by assisted living and sitter services and work with quite a few across the service area. But we also work with other clients. For example, I had someone call me Friday who, upon talking further, realized that her mother needs a gait belt. That's not allowed in assisted living. So on Friday, we're going to tour what I think are her two best options in skilled nursing. So we do work in skilled nursing some. It's not where we make money doing that pro bono, but I think it's the right thing to do for this family. And I want to do that. And that's how we go about what we do. We educate folks on share with them what are the best options. And then with that information, they make the best choice for their loved one. And that's what we try and do for all of our clients is educate them. And in that same vein, we feel like it's helpful if we can provide education to our referral sources who are social workers and nurses. We are accredited by the Alabama Board of Nursing. We're also accredited by the Alabama Board of Social Work. And each of those say to us that we can provide 1.0 contact hour, and this is a supervisory hour for social work, and it's a live hour for social work because we use an online password protected evaluation. You must listen to the entire presentation to receive live credit. We also provide credit for CEUs that are recorded and posted to YouTube like today's. I want to thank again our speaker today, Dr. K Nicole Brown, who is a frequent speaker with us and a very accredited and credentialed clinician. And we're so glad to have her speaking to us today on the topic of supervision. And it was asked in one of our evaluations, again, you must do the evaluation to receive credit. It was asked in one of our evaluations if we could cover a topic with supervision in long term care. So Dr. Brown has graciously included that in today's presentation. Let me read for those who are on YouTube and those who can't see the chat what our survey link is for today, and then I'll turn it over to Dr. Brown. Our link is https://www.surveymonkey.com/lowercase r/ all uppercase letters and numbers W, M as in Mary, B as in boy, 5, X, 9. That's our survey link. I've posted it in the chat room for you. And now, Dr. Brown, thank you so much for being here. We look forward to really hearing what you have to say.
Oh, thank you. Good afternoon and welcome, colleagues. I'm Dr. Brown. I'm a licensed clinical social worker and a clinical supervisor. And today we're going to dive into a critical area of our work, and that is ethical decision making. And whether you're in long-term care or short-term care, rehab, ethical challenges are everywhere. And this session is designed to be interactive throughout and provoking and directly tied to real world settings in your practice. And we're exploring real world tension between clinical demands and ethical obligations. So today's training is about more than what's written in policy. It's about who you are in the room and how you lead ethically and how to stay grounded when it gets hard. So I was thinking, you just think in your mind or write down an ethical challenge that you faced and or something that you thought about hypothetically. And maybe we can get to some of that as we begin. And here are our learning objectives. And the goal is, our goal today are urgent and essential. This isn't just theory, so we're not just going to be talking about theory. It's about equipping you with practical tools to navigate the ethical complexities of clinical social work. We're going to examine real life dilemmas and, like I said, long and short-term care, and when autonomy clashes with safety, and informed consent meets cognitive decline, and sometimes policy overshadows that person's autonomy and their personhood. So I'm putting this here only for the fact of saying this is how I am qualified to teach or to speak to you about what we're talking about today. A quick note is I am accepting supervisees, but I bring a full clinical experience into this session, and I look forward to talking to you more about what I've learned and things that I do know. And if you have any questions about what you see here or any other, you can contact me and I can answer any questions for you. So I'm going to in social intelligence a little bit, and we're going to talk about what long-term care is. Long-term care facilities provide ongoing support for individuals with chronic illnesses, disabilities, persistent medical needs. The facilities provide ongoing care. So those people usually are there 24/7. Their activities and daily needs are being met there. They have chronic illnesses. And usually in these types of situations, they're not able to return home, or they're not returning home anytime soon. So you can think about these as nursing homes, assisted living facilities. The focus here is to maintain and improve quality of life for these residents, and you may see that they need assistance with their medications and management, and usually social activities happen here too. So they get socialization here as well. Okay, so short-term facilities, they focus on rehabilitation and recovery and helping the individuals regain independence after a major illness or injury or surgery. These are skilled nursing facilities, rehab facilities, and the focus is restoring function and in a safe environment so that they can return home. And the stay is limited to a few weeks or a few months. So some of the examples of the services they receive are physical therapy, occupational therapy, speech therapy. And of course, they have skilled nursing care here too. So, and I'm a social worker, and there may be some nurses in the audience, but I will speak to what I know best, which is the NASW Code of Ethics and the core values that we hold. Ethics isn't just a set of rules; it's about how we show up. And for social workers, there are 6 values that that service everything that we do, or that are our moral compass, and it helps each one of us out in guidelines of what we should glean toward in real life situations. So service for social workers, our primary goal here is to help people and address their social problems, their social needs. We prioritize clients' needs over our self-interest or financial gain. For social justice, we are there to ensure and dismantle systematic oppression like racism and ableism, ageism. And we also speak to when we notice disparities in the care of our patients. So maybe a Medicaid client being discharged early or a Black resident receiving fewer mental health referrals or services or pain management. We talk about dignity and worth in the person, the importance of the human relationship and how that helps heal the person, and integrity and competency. And I think that just speaks for itself there. And so this is what I just put it together and says, this is how clinical settings and in the long-term care setting and short-term care setting, this is how you can kind of look at this as a quick fix of what this does. It's basically what I just said, but in a more condensed form. Some people are more visual than they are auditorial, so I gave you something visual there. All right, so this talks about some of the key differences and how they're summarized. So, of course, short-term care is temporary. Long-term care talks more about the patient being there for a longer period of time and the focuses. So this is another way of, these are two slides that explain what I just said in a shorter version. Okay. So let's talk about some common ethical dilemmas, and there are several of them. These dilemmas come up often and are not always in black and white. For example, what happens when a client in a long-term care facility tells you something dangerous in confidence, but they're also your supervisor's favorite resident, right? Ethics in practice often means choosing the least wrong option. Put that in quotation marks, the least wrong option. These the conflicts show up sometimes subtly, and it's rare that there's going to be a right answer every time. But what we're trying to do is do the most good with the least harm. So ethical dilemmas in social work and in nursing care are complex situations where two or more ethical principles are in conflict. And they may involve a compromise of what you feel is your values personally, or a compromise of what your patient feels are their values. We don't want to be hypocritical here. And think about ourselves. So when we're thinking about, confidentiality versus the duty to warn, or a dual relationship, meaning, your client she's not only your client, but you do her hair from time to time. And then we're talking about autonomy and the protection of our clients. So what makes something ethical, or the dilemma ethical, unethical, or ethical? An ethical dilemma arises when no choice fully resolves the conflict or the ethical obligation. Each action carries out a potential ethical cost or compromise, and you must decide based on the competing priorities or the contextual factors. You must make a professional judgment. Sometimes there is no right answer, right? Here are some other common dilemmas. Confidentiality versus duty to warn. There's a safety issue here. And maybe you have promised that client confidentiality so that you could build their trust. But as a professional, you have a duty to warn. So it's always good to use the TerraSoft doctrine and HIPAA here, where you say it up front that in the event of this, I must break this confidentiality and I have a duty to warn. That way you're still building trust, but you're allowing them to know what's up and what could happen if this dilemma comes up in the future. That way you don't feel like you're breaching confidentiality, but you're also still building the trust. And then what we all usually come up with is autonomy versus the best interest of the client. An example in a long-term care setting is a cognitively intact older adult refuses life-saving medication, but the family wants the medication. But we have to, the conflict is respecting their autonomy versus professional responsibility to promote their well-being. So a reasonable strategy is to assess the capability of that person. If it's intact, then you're supposed to support their decision, although you will get pushback from their loved one. All right. So here's the case scenario. A resident confides in you suicidal ideations. The family insists on no psychological involvement, and the facility staff discourages escalating it. What do we do here? I'm going to say correct response. We're going to assess, and we're going to document, right? We're going to, as social workers, we're going to consult our code of ethics, and we're going to notify our supervisor and initiate a safety plan, right? Your duty is to assess safety and document thoroughly. Involve your supervisor. Intervene where necessary. Ethically, client's well-being supersedes family discomfort or staff convenience. So I picked out 3 models of ethical decision-making. And these are 3 of the most popular. And they provide a good, robust information about what we as clinicians and as care workers can do to help protect ourselves. So the Reamer's 7-step model for ethical decision making guides you through a structural process to analyze and resolve ethical dilemmas. The steps involve identifying the problem, gathering information, considering ethical principles, exploring potential actions, evaluating the consequences, and then making a decision. So you go through a couple of steps. You're going to gather all your data. You're going to consider the law. You're going to choose the best or the least of the 2 options. You're going to control damage is what you're going to do. Now,
sorry to interrupt, Dr. Brown. Selena Allen, I think relating to the last situation, says she would assess for the risk of lethality, intent, and means.
Yep.
Sorry to interrupt.
No, absolutely. That's what this is for, y'all. Talk to me. Absolutely, talk to me. The Delft ethical principles. This is a little, some people may think this is a little cutthroat because it's based on a hierarchy of principles that talk about what precedes for conflict. So the framework emphasizes that the protection of life and autonomy are not equal. One holds greater weight. And when you're using this model, you are going to protect life at all costs. So while autonomy is the right to self-determination, it is a key principle. We're looking at the least harm over autonomy, but at all costs, we're going to protect life over their privacy.
I'm sorry, which one was that?
It's the one in the middle.
Dolgoff and Lowenberg. I mean, that sounds highly controversial to me.
It is highly controversial. So it says that in this situation where someone's life is in danger, the need is to protect their life. And it's going to override the need to maintain confidentiality.
Uh-huh. Where do you
So,
fall on that?
I'm sorry.
Where do you fall on that?
I really, personally, um, personally, I agree with protecting life. Like if someone's saying, you're in the long care facility, this person has access to a firearm. I know that may be far and few in between, but they are, threatening to harm themselves. I go toward protecting life over the confidentiality of the of things. I
Uh-huh.
would I would definitely look at confidentiality and telling the people that need to know, not everybody that doesn't need to know, right? Your
See,
supervisor, maybe calling the authorities, for some help, but most definitely wanting to preserve and protect life, especially if this person doesn't have a DNR.
right. Jennifer Calder asked, I'm not sure, and maybe she could give more information. She said, talking about a threat to another person that was voiced by your client,
Mm-hmm.
question mark, question mark.
Yes, you are obligated, and if you're using this theory, you are obligated to protect life over confidentiality. So if your client says they're going to go over to somebody's house and do that thing, then if you're using this theory, then you will break confidentiality to protect life. Okay, and then the last framework, it's a little more structured, and it navigates the dilemmas, emphasizing a thoughtful process rather than a quick, impulsive decision. So the last one, the one before this, was quick and impulsive, like something needs to be done right now. So I picked three models: one moderate, one severe, and one a little more laxical. And the last one, the framework involves a lot of key steps. You're going to identify the problem. You're going to apply your ethical principles. You're going to review relevant ethical guidelines and laws. You're going to generate a course of action. You're going to consult with people. You're going to consider possible consequences. You're going to then make a decision, implement it, and then review your decision. That's a lot of steps there. And usually you have a little more time. This one I wouldn't use this one if we're talking about life and death and we need to make a decision in the next 10 minutes. Yeah. All right. Client in rehab has early stage dementia. Family demands you force the patient into a DNR despite the patient refusing. What are we gonna do? Here are the ethical actions. Here are some possible ethical actions that you can use here.
Some questions. Is there
Okay.
a DPOA? Ms. Calder says respect the autonomy of the patient.
Mm-hmm.
And Ms. Dean says the patient's wishes always come first.
Always. Absolutely. If this patient is lucid, you always respect their wishes. And another thing that I wanted to talk about here, that we could talk about here, is to make sure that, in this particular scenario, the client has early stage dementia. That doesn't mean that they are not lucid and within their cognitive abilities. So what you could do here is you can continue to assess your client to ensure that they are making clear-headed decisions.
That's what Ms. Carter said. And I think it was Ms. Dean who said you do what the patient wants.
Yeah, do what the patient wants, but at some point, even within this, reassessing your client is a great idea to make sure that even you're on the right side of the law and ethics, to keep reassessing your client. Are they okay? Can they, do they have the capacity to make these decisions, right? Because then you start teetering over into legality of getting a proxy or someone else to help make those decisions. But when your client is lucid and they are able to make those decisions, you do what your client wants, even if it's not what their family wishes.
Ms. Dean points out that with the issue of the durable power of attorney, it's only effective if the client is incapacitated and
Absolutely.
unable to make their needs known. And in your example, that was not the case. Ms.
Mhm.
Nix says capacity is also decision specific. Someone may need assistance with managing their finances, but are able to decide what activities they'd like to do that day.
Absolutely. We're getting to that. She was ahead of me. Thank you, girl. You're a little bit ahead of me, but I appreciate you. We're on the same track. Great minds think alike. So, um, confidentiality in institutional practice. HIPAA. Clarify HIPAA rules in facilities. In your facility, know what your policies are. The minimum necessary standards. Make sure you know what those are, right? And on these type of facilities, confidentiality is messy. Okay. Just because a nurse asks doesn't mean they need to know. Okay. Using minimum necessary standards. Institutional standards also often challenge confidentiality, but you're supposed to protect your client by clarifying and assessing. And people even on the team, they get information as they need to know. But we're such a society where we want to share, but everything does not need to be shared. Okay. Someone's HIV status is not everybody's business. And it's on a need to know basis. Maybe you need to know, maybe the nurse needs to know, maybe the doctor needs to know. But nutrition does not need to know, right? So be careful about this, because sometimes these people in these facilities, they, especially long-term facilities, they become like family. Somebody becomes like your pseudo aunt. And so those roles get enmeshed. And sometimes when you're sharing charting systems, be careful, social workers, what you are putting in the chart. You only want to chart the things that are necessary for care and life of that patient. If they told you they won $100,000 yesterday on a scratch off in Mississippi, that does not need to go on the chart. Why does that go on the chart? I'm just saying that as something. Why does that need to go on the chart? But if they're saying, I went to the doctor and I found out that I have a cold, that needs to go on the chart. Or, my loved one has passed away and that person usually helps me make my decisions or pay my bills. That needs to go on the chart. But hey, Miss Such and Such has a new boyfriend. Is that necessary to go on the chart? Just asking. All right. Can a dietary aide read your notes if they're a part of the team? What are they saying? Can dietary read the notes?
No questions or input yet.
Okay. Well, I'm gonna give you the answer.
No, says Miss Alexander. No. Miss Hinton, Miss Dean, Miss Calder,
No,
Miss
dietary does
Johnson.
not need to read the notes.
Oh, lots of no. I can keep up with the no's.
No, dietary does not need to read the notes. Um, does does the hairdresser need to read the notes? So the cosmetologist? No, the cosmetologist does not need to read the notes. There are certain people that are part of the team, and we love them and we need them to be a part of the team. But be very careful about what you share with whom, even if they're on the team. If it's a medical need, nurses definitely need to know. Doctors definitely need to know. PT, OT, depending. But do they need to know that your client is sexually active? No. Be careful about what you share with people. Because like I said, in long-term care facilities, people start getting enmeshed like that. It becomes a family atmosphere, which is great. However, it's still a business. And you're talking about other people's business. So be careful.
Ms. Calder says food choice preference you might share.
Absolutely. That you can share with dietary. If they have um textural issue, if they have an allergy, most definitely share that with dietary. Most definitely share that with all kinds of people. Peanut allergy, for example. Everybody needs to know that because some of us may eat peanuts, don't think about it. You touch something and then your client touches it and now they're having a reaction. Nobody has any, you don't know. So those things you do have to be careful about. So yes, you are correct. Informed consent, more than a signature, because yes, it is. True informed consent is ongoing. And I think we were talking about this about 2 slides ago. Long-term care facilities, dementia progression can change the game from week to week. And reconsent is regular. You need to be checking their cognitive abilities, their cognition, and especially with dementia and how it may progress. Now, I'm not an expert. I will say that, and I will add just a personal piece. I'm dealing with this with my sweet mama right now, who is having early on stage dementia at an early age. And we have to constantly recheck her cognition to make sure that she understands what's going on. Because sometimes if you've dealt with patients with dementia, it kind of wanes and weaves a little bit. Sometimes they're very lucid and they understand everything. And then maybe a couple of days later, they're a little confused. So you have to make sure as a clinician and as a nurse that your patient understands what is happening all the time. True consent isn't a checkbox. Okay, it's rational. And involving settings like dementia care, you reconsent ethically, do it all the time so that you make sure that you know and you've documented that that client is in their right lucid mind at that time. I did say that it's a continuous battle and it's a continuous process. And make sure that you're understanding that from a cultural process aspect too, because sometimes wording in cultures is different. So my background, ethical background, ethical. My parents are West Indian, and that is like the islands of Jamaica, those islands, and Geechee Gullah. Some words that we use here in America are insulting to other people there. So make sure that you're paying attention to culture as well, especially with consent, because there are some cultures where the eldest person in the family makes decisions. But we know that we do what is best for our client and what our client wants. However, we do want to honor their culture as well in the context of informed consent. Does that make sense to everybody? I hope so. And I'll go back if not.
Yes, Ms. Taylor says.
Okay. Key elements of informed consent is disclosure. Be 100% real with these people. Tell them what they need to know. Make sure that they understand the nature of the proposed treatments, the procedures, the medications, the benefits, the risk, and the alternatives. So here's what happens. I took my sweet daughter to get a procedure. And what they come in and is they give you a whole bunch of papers. They say blah, 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 and then say, here you go, sign these papers, saying that you understand. But if you don't understand, slow those people down. And as the people we as the medical professionals, we need to slow down and make sure that we make sure that our patients in long-term care and short-term care understand what they are getting themselves into and that they agree to it. Because sometimes they just say yes because there's so much going on, it's so much information. They just say yes because you're just talking too much. And they're like, yeah, whatever. Just do it. But then when it's time for them to do the thing or participate in the procedure, they're like, no, I don't want that. And you're like, well, you signed saying that you agree, but they just kind of signed just to get you out of their face. To be honest, it's pretty overwhelming. So take your time and make sure that they understand what's happening and then that they can ask questions, because sometimes there are middle grounds that you can get to in helping them. Make sure that our disclosures are very clear. Understand people are signing on their own fruition and it's voluntary. And let them know that they can revoke their informed consent at any time. Because sometimes people they don't know that they can say no. Because if you think about this, when we're talking to our clients, we sit in the seat of authority. And when they are depending on us to help them because they don't know. So we sit in the seat of authority. So what we want to do is make sure that we humble ourselves even in that place and letting them know this is the risk, these are the benefits, that you're doing this. We're not coercing anybody, influencing them, and that we let them know that they can revoke their informed consent. And that we give them documentation and it's in writing. And sometimes what I even do is I highlight stuff for people. I underline to make sure that clients understand and their families understand, because there's a lot coming at them and you are the face of the company. You are the face of the nursing staff. You are the face of the social work staff. They don't get to see the CEO. They see you. They want to trust you because these people are going to be living in this long-term care facility or they're going to be visiting this short-term care facility. Make sure that you do your due diligence in making sure that they understand everything that's going to go with their treatment, because you are the face. They don't get to see the CEO.
Ms. Ward says she never signs anything without reading or having clear understanding. She knows,
right.
My doctor hates me sometimes. I also say, make it plain, please.
Yep. Let them hate you, honey. Let them hate you. Because see, they do it all the time. And they say it all the time. They have a spiel, right? So they're just going through the spiel and they're like, okay, so yes or no. Are you going to do the thing or you're not going to do the thing? But for us, this is our lives. For your loved ones, these are their lives. So you have to really make sure that you understand these things. Even for me, when I do, like psychological evaluations, I do them all the time. So it's a boom, 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 boom for me. But think about for somebody who doesn't understand it, it's not a boom, 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 right? It's a, wait a minute, you want me to do what? You want me to sign over my what? I'm not going to be able to do what? So I can't have my friends over. I'm going to have a pacemaker put in. I know I'll use my own self as an example. When my mom had open heart surgery, I stopped the presses and I said, okay, who's going to be in the room? What is their role? Who's not going to be in the room? What types of things are going to be used? I made them like stop what they were doing, because usually they have like 15 minutes. You go to the doctor or they come to your room. The doctor's in there and they make the rounds early in the morning when the roosters haven't even come out. And they say what they're going to say and they leave, right? I made my doctor say, I said, honey, have a sit down. We have to have I have questions. Come with your questions. And make sure that your patients come with their questions. Help them with their questions, especially if you know. Residents in long-term care facilities have the right to participate in their decision making. including accepting and refusing treatment. It's not up to us. And staff should engage with the residents and discuss their care often and give them choices and respect their preferences, right? Even in those short-term care facilities, it's similar. They still have choices. They are not in like lockup. It's not jail. It's medicine. And we're there to help them get better or to help them along their journey in their ages and stages. And with hospitals, they're very short term and they have specific protocols and forms, but make them show it to you in writing. And then also, you as the clinician or you as the nurse, know your policy. And when you see something, help your clients. If you know that they're struggling, say something, help them out. It goes a long way for you to build trust with your client and for them to trust you in those moments where they don't know what to do. They will look to you and say, okay, what are my options? And you may say, well, this may be the better option. Give them the 2 or 3 options, let them make a decision. They're going to trust you if you treat them like a partner instead of treating them like a number. Dual relationships, boundary issue. Okay, in tight-knit care environments, boundaries are blurred. Maintaining transparency and being neutral. A smile is free, but gifts aren't, right? You have a sweet little client, she crochets, she wants to give you something, she's going to crochet you a blanket. Sweet and nice. Make sure that you know what your policies are for your facility, right? Boundaries doesn't mean distance or distance ourselves, but we do want to protect ourselves. Because as a professional, we can get in a lot of trouble for accepting gifts or meshing those boundaries, meeting somebody's daughter outside of the facility and going to a movie with her. That's a boundary issue. Be careful with that. I would say don't do it. Err on the side of caution. And think about some of those times where you had to navigate, those close ethical situations where you've had somebody and they've been your patient or your client for 3 or 4 months, and you just feel for them. But have you ever been overly emotionally involved with a client? What did that look like? So documenting, I want to talk to you about documenting. We want to document what's relevant, and your notes should defend your license. Assume every entry that you make may be read aloud in court. If you don't want it read in court, do not type it. Make sure you don't have any errors. Make sure you don't have any typos, right? So think, if a judge reads this out loud, would it honor your client's dignity and reflect your ethics? So an example would replace "a client resisted" with "a client expressed discomfort and declined today's intervention." Because when you say resistant, it puts a picture in somebody's head, right? Instead of saying manipulative, that the client was manipulative, you could write "the client attempted to change the topic when discussing medication adherence." Same thing, whole lot more wordier, a little flowery, but it changes the tone of what you were trying to say. Because if you just say they were manipulative, well, you have to defend that. What does that mean? Explain that. Well, if you do the alternative, which is the client attempted to change the topic, then what you did was you explained what happened and how the client behaved. I hope that makes sense. I know it does. We got some smart. We're all smarties in here.
Oh, there are many people saying excellent tips, and that's good. And thank you.
Yeah, I appreciate that. Okay, we're going to talk about telehealth because telehealth is booming. I am in telehealth myself. Don't assume telehealth makes ethics easier. If a client is in a noisy background, that means that your session is not private, and that's a HIPAA violation. Telehealth bring both access and ethical complexity. What if a client's partner is listening off camera, or they're walking with their best friend next to them, and they want to talk about, I don't know, their sexual escapades, or they want to talk about their status, their medical status? Well, that's not appropriate because that other person doesn't have a release of information, and you can't talk about that with that other person in the room or with that other person present. So you must assess the environment, and those are some red flags. So sometimes you have to turn down a telehealth session due to poor conditions. But you do respect their environment, but you make sure that you protect yourself. Culture can't justify harm, and it does shape perception. We must bridge, not bulldoze. Cultural sensitivity isn't a checkbox, it's an ongoing responsibility. So ask, don't assume. All right? Supervision is the ethical armor. Put on the full armor of supervision, please. Good supervision protects your client. It protects you. It protects your license. It protects your peace of mind. So do not fly solo. And this is what I tell all my supervisees. Because if I am your supervisor, you're working under the guise of my license. If you do something that is unethical or outside of your scope of practice, not only are you going to be hit, I'm going to be hit. So you're going to have two conversations. You're going to have a conversation with your board, and you're going to have a conversation with me, because now my license is in jeopardy because you are my supervisee. I protect my supervisees at all costs, but what I ask you to do is let me know. Yeah. Supervision is where ethical clarity happens. Don't wait until you're unsure or the crap has already hit the fan before you bring this question to your supervisor, meaning your clinical supervisor. You may have a conversation with your actual supervisor, but if you are under supervision for a clinical license, it is in your best interest to always let your clinical supervisor know. And you have to have a good relationship with that person. So, fatigue and bias and burnout, exhaustion. Social workers take unethical shortcuts, and we're human. Burnout doesn't just harm us, it impacts decisions. All right, sometimes what's legal is not always what's ethical. Ethical encourages all. It also sometimes it goes beyond law, and we all know this, where doing what's legal isn't always enough. Our ethics often ask us to go further to advocate. But you have to know the scope of your practice, know the law. Red flag. Sometimes they're everywhere. If your gut clenches, pay attention. Red flags are not for decoration, okay? Have you ever been pressured to document something untrue that you did not do? Or they said, the person before you quit and we need a licensed clinician to sign this paperwork, but you didn't see the client? Red flag, red flag, red flag. Call your supervisor, red flag. Say no, red flag. Okay? That's an alarm. But if you feel it in your gut, you need to pause and consult. Going back to the NASW, you're not alone. There are other ethical committees that can help, and community is our ethical safety. So here's your toolkit. Your toolkit consists of the code of ethics, your licensing board, your mentorships, decision-making models. There's a toolkit for that. And if you want a toolkit, I'll get you one. Let me know. Be the clinician who leads with ethics. Let that be your signature. So ethical practice is a daily decision, not a single act, and it keeps sharpening your judgment. And if you're working with your supervisor, iron sharpens iron. So what changed for you today? What ethical values do you need to nurture? Think about one word to describe how you approach your work from now on. So, shameless plug. Like I said, I am a supervisor. And if you want more conversation like today or want more information about that, I will be more than happy to do that for you. And to even if I can't be your supervisor, provide you with someone who will help with supervision. If you have questions about social work ethics, social how we do things, how we don't do things, or if you're a nurse or in another discipline, it's good to have a multidisciplinary team of people so you can bounce some things off of. I got you. Just let me know what you need.
Lots of great comments, great information. Thank you. I'll read for folks again, especially those who don't have access to the chat room on YouTube. The survey link is https://www.surveymonkey.com/lowercase r/ all uppercase letters and numbers, W, M as in Mary, B as in boy, 5, X, 9, J. And the password for this is supervision with a capital S. Supervision is the password. You must do an evaluation to receive a certificate. Just a reminder. Let's see, we have some more comments. Place in chat, I did. Thank you. Excellent. Great job. Thank you. Great information.
If there are any questions, I'm here.
No questions so far.
Okay. And even if you need to reach me, that's fine. Let me see. Go back. That's how you can reach me.
Thank you for a great session.
Thank you for having me. I love doing
yeah. It. I think we have you again this year, do we, at some point?
Just let me know what you need, Sean. It's all good for me.
All right. Thank you so much. Thank you all for being with us. Not next Monday, but the following Monday, the 28th, Dr. Andrew Duxbury, who's a noted geriatrician in Birmingham, will go through medications for the geriatric population with us. Ms. McNew, maybe I'm not seeing any other people having trouble with the password. So maybe close your browser, reopen, and try it again. It's a capital S in supervision. Ms. Ward says the password's not working either. I'll fix that, y'all. And thank you so much for being here. Oh, the password is working because I've gotten a response. So let's see. Let's see what's going on with the password protection.
Thank you, Brandy. I appreciate that.
All right, y'all. I'm fixing the password. Thank you all for being here. Please join us next Monday when Dr. Duxbury joins us, and please look for Dr. Brown to present again. The password is working. Thank you so much. Thank you so much. Also, nice comments, Dr. Brown. Thank you for being with us. Hope you
Thank you
have
for
a great
having me.
rest of the summer. Hope
Mhm.
those on the call have a great week and join us in 2 weeks. Take care.
Bye.